Hello, everyone. I'm Danilo Buonsenso. For those of you not following my blog, Buonsenso and the Kids, and as many of you have asked me to make more videos, I think there was a great suggestion. So I will try doing more and more videos for this space. I will still keep posting my usual written posts. So today I want to try to reply to a question that many people ask me frequently, even including colleagues, not only patients or parents. So why I do consider treating children, adolescents, or young adults with long COVID? And somehow this is an appropriate question because we don't have yet a formal pharmacological guidance for these patients, but I do think it's necessary that these patients need to be treated now. So, first of all, let me give you a very brief context about background about myself. I'm a pediatrician, but I have a PhD in global health and biomolecular sciences, which focused on COVID, multisystem inflammatory syndrome, and long COVID. I have two master of sciences in pediatric infectious disease. Actually, one on antibiotic stewardship and a postgraduate diploma in pediatric infectious diseases. So even before the pandemic, my job was about infectious diseases, including chronic infection like tuberculosis, but even viral infections like congenital infections and congenital viral infections like congenital CMV, cytomegalovirus infection, which is very well known. I think it's a perfect model about how a chronic infection, and usually an asymptomatic chronic infection in the newborn, can lead to post-acute sequelae like neurological deficits or sensory neural hearing loss. The topic about chronic infections and sequelae of infections was something that I was already working on before COVID. But with COVID, the whole scenario or my perspective was completely revolutionized, actually, because the number of children, adolescents, young adults that I have seen and I'm still seeing with the life completely disrupted since these patients got COVID is completely driving me crazy. It's completely surprising me day by day, and I think this is a really huge public health problem. And I think all our energies, resources, efforts should be really committed to understand and treat long COVID. So, what is the point about treating long COVID in children, adolescents, or even young adults? Because now I'm also taking care of young adults, usually up to 30 to 35 years old, because these patients are patients that were completely healthy before COVID, meaning a typical case is a 14-year-old boy or girl who was perfectly healthy before COVID, regularly going to school, not having psychological major issues before the infection, who was doing extra scholastic activities like playing football, volleyball, or any other sports more times during a week, going out with friends. And then suddenly these patients got COVID. This happened in 2020, 2021, 2023, and less frequently now, but still happening. So since having COVID, these patients have never returned to their pre-COVID uh, baseline. And I mean, it's not only being a bit tired or having some headache. These patients are really seriously sick. I have 14 years old patients that were playing football every day during a week that since got COVID were not even able to make it one floor of stairs without being very very tired, feeling difficulty breathing, having palpitations, being exhausted, and needing hours to days to recover to such minimal efforts, despite for years they have been playing several physical activities. Or I have patients that were top students at school, then got COVID, and since then they are complaining symptoms that are classified as brain fog, but I don't think brain fog really gives the full picture. These are children or adolescents who were getting very high votes at school, and since COVID, are struggling to memorize things, to have the same school performance. To they forgot things, they forgot words, they really struggle and need hours and hours more to study things they were used to study before in like minutes or 1 hour, for example. And these are and then we have a huge cohort of children having severe gastrointestinal issues, severe digestive issues, who are not able to eat anymore, needing tubes or stuff like that, or children suffering from fainting, syncopes, presyncopes, palpitations, or being eventually classified within the POTS spectrum or the orthostatic tolerance spectrum, or children with severe headache. So these children were super active, and since having these symptoms, most of them spent almost the whole day at home, laying down in a bed, and not because they are have a psychological problem or are developing a psychiatric disorders, because literally they have no energy for doing anything. Imagine if it's your daughter or your son having these symptoms, and the only reply you can have from a healthcare professional is go to a psychologist, go to a psychiatrist, or come on, try to fight more because you are just tired. So this is a very complex situation. And the main point, it's not only severity. So from some point of view, from some perspective, the quality of life of these patients is more severe than my usual patient before the pandemic. I will say that the quality of life of these patients is probably the most severe quality of life I've seen so far, except maybe children with cancers or children with the most severe spectrum of chronic autoimmune diseases. So this means that these are among the most severe patients, the most ill patients I've seen so far. And imagine having a 14-year-old child who is not able to go out with friends, doing any activity, going to school, and actually with even no hope because there is not even a single medication or a single therapeutic offered to give kind of a chance of hope to of recovery. You can imagine, for example, patients with cancer actually are anyway in any case being including in pharmacological approaches, pharmacological trials, or even off-label approaches. Even in those cancers when you don't have lots of hopes, but sometimes I've heard patients, in this case adult patients, telling me, when I had cancer, I had more hopes because at least I could try some surgeries or some therapies, and I had hopes. Now, with doctors telling me, we don't know, just wait, we really feel hopeless. And this is why some patients really, even young patients, sometimes talk with families about suicide, and actually some patients did it. I've had some personal experiences with that. So I think in such a severe case, we literally need pharmacological treatments now. I know that we don't have a formal pharmacological guidance so far, and having randomized controlled trials is the ideal situation. But we have a few things to consider, in my opinion. First of all, access to randomized controlled trials is not easy for a number of reasons. First of all, long COVID and myalgic encephalomyelitis are really little to no known in several countries. So not every patients in every countries have uh, the lucky to have main centers with access to dedicated funds for randomized controlled trials. And this is particularly true for pediatric patients who historically enter trials only after a formal treatment has been discovered in adults. So, yeah, very young children and adolescents are even more less lucky compared to adult patients. Secondly, even if in some countries there may be some centers implementing randomized controlled trials, this usually happens in a few or sometimes even in the single center, which is a dedicated facility for that specific conditions like long COVID. Meaning in a big country, the trial may be accessible for just a minority of patients. And when we have this minority of patients, this is a well-known bias in accessing trials by patients from minorities, for example, or patients from lower socioeconomic background, because the patients may need to travel, and when it's about long COVID, patients may also need to be aware of these conditions. And in my experience, it's usually families that fight more, that document themselves more, that are have more possibility to achieve obtain a diagnosis. And even another problem is that there is a very strong underdiagnosis and under recognition for this condition. So several patients, particularly among the younger patients, are not even diagnosed. And this means these patients will never have an opportunity to enter randomized controlled trials. But most importantly, most countries are struggling to find funds for randomized controlled trials. And even myself in my center, I'm having, I'm so far, I've not succeeded to access funds for younger children and adolescents, because from an ethical perspective, it's very complex to have funds when no pharmacological treatments are approved in adults. And the other point is that we usually don't suggest treatments to patients with long COVID, even if severe, who have symptoms since a few months. We know that some patients can self recover within 6, 9, sometimes even 12 months. But the cases I'm talking about, the most severe cases, are children or adolescents who are being ill since years, meaning sometimes even from since 2020 or 2021. Meaning, so in these patients, the hopes of recovery are close to zero. And these are the patients who are thinking about committing suicides or self-harms because they're literally desperate. In these cases, I do think that considering off-label medications is probably even ethical from some point of view. I know that usually people, doctors, including myself, we have the famous Hippocrates statement, which is in Latin primum non nocere. In English, it's known as first do not harm, which is true. This statement is from Hippocrates, so thousands to more than 2,000 years ago. And of course, in that period, it was ethical accepting the statement first do not harm. But is it this really ethical still in 2025, when we know a lot about this condition, which is long COVID and myalgic encephalomyelitis? We know several biological events happening in these conditions, and we know several medications that we are using since decades for other purposes, but we know that may have biological properties, at least in theory, able to tackle some of the events happening in long COVID. So in this context, is it really ethical to say, at least to the most severe spectrum of young patients with long COVID who are not having really hopes, and they are desperate and are not living anymore, is it ethical to say, okay, just wait? Is it even, maybe I do believe that when we say first do not harm, sometimes we may harm also when we say there are no options, there is nothing to do, just wait. So I do think that sometimes we are harming our patients when we do that. And this is particularly true because I think I seriously and genuinely think that long COVID is one of the most studied diseases in the history of medicine, because we have thousands of studies nowadays on long COVID and myalgic encephalomyelitis. We know we have the top level studies with the most modern diagnostics and methodologies that have clearly proved some events happening in long COVID: viral persistence, chronic inflammation, immune dysfunction, T cell dysfunction, thromboinflammations, this autoimmunity. These events have been clearly studied and documented by several independent research centers from different countries, and always replicated. So there is a lot of consistencies about autoimmunity, autoantibodies, the transfer. We have studies documenting that the transfer of antibodies from patients to mice lead to the development of similar symptoms in mice. We have several objective documentation. POTS, it's clearly documented. Dysautonomia, it's clearly documented. Chronic headache, brain and cognitive functions, CNS inflammation, viral persistence, thromboinflammation has been documented by countless studies. So in this setting, is it really ethical to say, to tell our patients there are no hopes, there are no medications? Are we probably harming when we see the most severe spectrum of these patients and saying we have no options? I'm not sure, honestly. So this is a question I also ask you. I ask these questions to myself, and this is why I sometimes have considered off-label medications. Another point is that in pediatrics, we use off-label medications like every day. I think at newborns with infections, or premature with bacterial infections, or even multi-drug resistant bacterial infections, multi-drug resistant gram-negative infections. So we don't have trials using the newest antibiotics in newborns or in premature newborns. But what we say, what we do when these newborns have infections, do we say we don't have evidence, we don't have trials? We use off-label indications from medications that we are using either in older children or in others, because otherwise they will die. And this can be replicated in several other pediatric conditions, because trials are usually only late or sometimes never being done in young patients. So we don't have trials for hypertension in newborns or pediatric patients with comorbidities, but we use off-label indications to translate um, different dosages of medications that we use in adults. So we have routine practice with off-label in used in pediatrics, but most importantly, we have some medications that we are using since decades. Like I can think at intravenous immunoglobulins. I'm not saying intravenous immunoglobulins will cure long COVID, but if they can make 50% of patients feels at least better. And we use IVIG, intravenous immunoglobulins, since decades, even in newborns with for example, thrombocytopenia due to maternal autoantibodies. So we really have experience. We have experience with anticoagulant prophylaxis in children with traumas, for examples, or of children who cannot move because of fractures or whatever. We have many people are talking about rapamycin in this period, but we have pediatric patients with autoimmune disorders or genetic immune deficiencies which are using rapamycin since years, and I can say rituximab, I can say other biological agents. I'm not saying this is need to be routine practice. Of course we need trials, but access to trials is very difficult, and in the most severe cases, I think it can be really ethical at least to discuss off-label opportunities with our patients and with our families. Of course we need to sign contents, we need to discuss pros and cons with patients, but stating a priori no, there are no options, I really think it's not entirely ethical, because we may harm sometimes even when we do nothing. And I think it's particularly true in 2025, when we have several biological mechanisms which are clearly demonstrated, and several options that may be repurposed, at least for the most severe cases. So I think this is why we should consider in some cases to treating young children long COVID, because long COVID can be a really devastating disease. One of the most, honestly, I'm saying this honestly, one of the most devastating diseases I've ever heard. So please let me know what you think. And sorry for my English. I'm Italian. I'm not a native English speaker, but uh, as I'm following several families and patients and colleagues from all over the world, I thought speaking in English would have been more effective. Thank you very much.